Visible now?
Yeah, it's visible. You are audible also.
Thank you, everyone. It's really an honor to be, with you guys, sharing our experience. Unfortunately, my topic is not that much talked about because if you see in our poll as well, the outside in repair was not, featured. But I think we have to understand what is this technique and why in Nepal we use it. In my practice, this is about 70% of all cases that goes with outside in repair. So this is all. Oromugam talked about inside out. Rajiv Raman will talk about all inside. So my job is to talk on outside in. If you see the disadvantages, all inside technique is very costly, and majority of our patient, they are not. They have to pay out of their pocket, so they are not ready to use all those things. If you talk about disadvantage of inside out, as Oromugam also said that it requires safety incision. Most of the time, this requires incision, and it is multiple incision. One of the disadvantages of outside in is this is a very cheap technique, and nobody promotes, this technique because not much of things are involved in this. Probably that was the reason why outside in technique. One of the reason why outside in technique is not very much popularized. So if you look at these commonly used techniques, so if you use a inside out technique, this is a animation that we have prepared. So you have to apply suture. If you have applied suture on the superior surface and you tighten it, the inferior surface will open up, or the meniscus will flip up or down, depending upon where you have applied suture. So what you have to do to close that, you have to apply on the inferior aspect also, as Oromugam was very clear on his presentation. So same thing happens with the all inside technique as well. It can be applied either in the superior surface or in the inferior surface. So it is, if it is applied in the superior surface, then you need to have some supplementary suture anchors or suture applied on the inferior surface as well, so that you close the gap circumferentially or you close the gap completely. So this was already mentioned in 2013 by Justin Salomon, and then this is the picture taken from his presentation, which says that probably you need to apply a circumferential suture so that you get a good compression at the tear site so that it heals. And he has demonstrated how all inside technique opens up the other surface of the application of the suture. So what he explained that if you apply a circumferential suture like this, then there will be a even compression on the longitudinal tear of the meniscus. And for this, he developed a new device. But the disadvantage of this technique is you need a good amount of periphery of the meniscal tissue so that we can apply this all inside circumferential suture into the meniscus. So what we did was we modified this circumferential compression technique, and we published this technique in arthroscopy technique in last year, 2020. We published it. But however, we've been using this technique for last 4 or 5 years. So what is this technique? Is this is essentially an outside in technique. We named it as a suture shuttle technique. So what we do is we come above the meniscus, then we pierce the meniscus with the epidural needle. Once the meniscus is pierced, then you pass a stout suture, which is about 20 proline suture. Then take it out from the anteromedial portal and use this suture, proline suture, as a shuttle suture, so that you can shuttle the high strength suture back. Once you have passed on the superior surface through the meniscus, then you give a second pass again with the same needle. Now you come inferior to the meniscus. So in this time you are not purchasing any meniscus. So what you do is you take it out again. So you use this suture to shuttle the other limb. That is why we have named this technique as a suture shuttle technique. And then you tie it, both the limb, pull it out with a small incision. I'll show you how we do that, and you tie it down. So this will give rise to a circumferential compression. So this is our technique. almost 99%, almost 100% of my cases, they require a pie crusting after assessment of the repairability of the meniscus. I will definitely do a pie crusting before I decide to do a meniscal repair. So as we were discussing, I do in the joint line, pie crusting, and after pie crusting, it's widely opened. Then you must visualize the periphery of the meniscus through which you are going to repair. So this was a small another bucket handle on the periphery. So we have to remove that so that you make it. The receiving bed has to be really healthy because all the vascularity has to come from the receiving bed. So the receiving bed shouldn't have any flaps or anything. So you remove that. Then I use a very low suction shaver so that I can do a stimulation or remove some of the synovial membrane of the periphery so that it bleeds. And then I remove the flap also. Then next step is to use a diamond rasp. So this is still we are preparing the meniscus. This is the diamond rasp, and it is important to rasp the inferior portion of the periphery. That is the portion, the tibial portion of the periphery from which the vascularity comes. So it is important to rasp that so that your bed is well bleeding. You can see that even with the tourniquet, you could see the red dots on the periphery. That means that your preparation of the periphery is good. So since I wanted to make it very cost effective, we use the normal cannula on the anteromedial portal to shuttle the suture. Now you pass your epidural needle, and you can see that you can use the curve of this curved needle to negotiate your needle through the meniscus and from where you want to come. So once the epidural needle is passed, then you pass we use a proline suture to pass this 2-0 proline suture, and then take out this proline suture from the anteromedial portal. Remember that your scope is all the time in anterolateral portal when you are doing a medial meniscus repair. So what you do is tie a knot over the loop of the high strength suture. In this case, I'm using a 2-0 orthocord. Another very important step is give just a stab incision on the skin and make a soft tissue tunnel. So this is a very important step in which you have to make a deep soft tissue tunnel which will go right up to the capsule. You spend some time on making this soft tissue tunnel so that every suture you pass on that region goes through the same soft tissue tunnel so that there is no. So then this is the shuttling of the suture. You pull that tail of a orthocord out and then pass your second suture. This is coming from inferior to the meniscus, and the same process is repeated. Remember that this needle is coming from the same soft tissue tunnel which has been created while passing the first suture. So you again take it out and then shuttle the other limb which is in the anteromedial port. So we are taking the proline out, tying outside, and the shuttling and pulling it out. So the both limb will come inside. So this is what is called the cheese saw cutting movement of this thread. Since these thread are not monofilament, multifilament, so it can act as a saw to a very soft meniscus, so that we can use sometime if you have to do excessive movement of the suture, we can use this probe so that you prevent all the movement or prevent the stress from the meniscus. So this is the second pass of mine. Remember that this is right at the posterior horn. You can go even posterior. What I do is I put a middle one first so that I see the adequacy of reduction of the meniscus, and then I adjust other suture. So I go to posterior and then I come to the anterior. So this is the coming from the inferior side. The previous one was from the superior one, and then you pull it up. So I'll cut short this video a little bit and then show you how I tighten it. So this is you can see that this is the circumferential compression, and with this suture there will be no eversion, nothing. You'll get a good circumferential compression. So while tightening, this is what one of our colleagues was saying, that the cheat saw cutting mechanism of the suture, can this happen? So I always use a probe underneath the suture, so that majority of the stress is borne by the probe, not by the meniscal tissue. And then from external side, I apply a SMC sliding knot, so that I make sure that this knot slides right up to the capsule. Why SMC? Because it is a sliding locking knot, and this is very small knot. So if you make a good, nice soft tissue tunnel, which is going from skin to soft tissue, again the second complication of this type of technique is palpation of this knot, or the feeling of this knot will not happen. So here what I'm doing is tightening. Then you can tighten them one by one. So I usually, when I start tightening, I usually start from the posterior side and then come to the anterior side. So this is the final one. I have removed the stabilizing suture, and this is the final repair of the meniscus right up to the posterior horn, and with a very cheap and easy technique of outsiding technique. So what I do next is again important to go through the soft tissue tunnel and cut the thread well inside the soft tissue tunnel. This case also had a ACL tear. So in this particular case, we repaired ACL and then we repaired the meniscus as well. And you can see that the nice fluence of the flounce of the meniscus has appeared. And this is right up to the posterior horn. So some advantages and disadvantages of this technique is, it is low cost procedure that can be done with locally available materials in every operation theater. In Nepal, we say that surprise lesion, which was not detected in MRI, which were not counseled during the pre-operation counsels, and there are many surprise lesions. So probably these are the lesions which are tackled in our context with a very cost-effective technique. Both vertical and horizontal mattress suture can be applied, or you can do a combination depending on the tissue quality. If your tissue quality is good, then you don't need to apply a horizontal and the combination of the vertical and horizontal. This technique is quite reproducible, can be used to repair the longitudinal tear of any part of the meniscus, and we have extended its use on the lateral meniscus as well, but we have limited right up to the popliteus tendon. So any tear on the lateral side, longitudinal tear on the lateral side, which is anterior to the popliteus hiatus, can be repaired by this technique. Some of the pitfalls of this technique is pie crusting of superficial MCL is almost always required in this type of repair. Orientation of suture may not be vertical, especially when we talk about the posterior horn repair, but the same thing happens to the other type of repair as well. And a relatively larger knot passes through the meniscus because you are shuttling, so there is a combination of the Prolin suture as well as the loop of orthocord. So there is a relatively larger knot that is passing through the meniscus, and then its consequences we still don't know. Fortunately, we have not received any tear from the suture passing place of the meniscus at this point. So with this, you can go to the arthroscopic